This conference will now be recorded.
So today's topic is regarding physiological changes that are happening in the pregnancy. So what are these physiological changes? These are the changes that happens in the pregnant mother to accommodate the growing fetus. These are all the physiological changes. They are not pathological. So you have to know them because you have to differentiate between the pathological conditions from which you can treat them. So coming to the introduction, the physiological changes are either it can be anatomical or functional, that is physiological or biochemical adaptations to the pregnancy to accommodate the growing fetus. So these physiological changes usually begin from fertilization itself and they continue throughout the pregnancy. And these maternal adaptations are according to the increased demands of the growing fetus, as I've already said. And all these physiological changes, they will return to almost the pre-pregnancy state after delivery and lactation. So the anatomical, physiological and biochemical adaptations to accommodate the growing fetus, which begin after fertilization and continue throughout the pregnancy and returns to normal pre-pregnancy state after delivery, are called as physiological changes of pregnancy. So the major maternal physiological adaptations in pregnancy, which we usually see, are in reproductive organs, the metabolic changes, cardiovascular hematological changes, and changes in urinary tract and renal function, pulmonary changes, GI changes, and endocrinal changes. So now we are going to read according to these headings like reproductive organs, metabolic, cardiovascular, hematological, renal, pulmonary, GI, and endocrine changes. So coming to the reproductive tract physiological adaptations in pregnancy. So the structural adaptations we'll talk first. After that, we'll go for the functional things. So coming to the reproductive tract, the major reproductive organ which is getting physiologically adapted during pregnant state is uterus. The uterus is in a pre-pregnant state is usually about 70 grams, which goes up to 1.1 kg during pregnancy. And its capacity increases from 10 ml to 5 to 20 liters. And if you can see by term, it is getting greater, like 500 to 1000 times greater to the pre-pregnant state. The major changes that occur in a uterus is in the myometrium. The myometrium wall usually it gets thickened by 1 to 2 centimeters. It's not millimeters, it is centimeters. And this change in the myometrium is due to hypertrophy of the muscle cell, and limited hyperplasia is also seen. Hypertrophy is enlargement of the single myocyte, and hyperplasia is its numbers getting increased. So major thickness of the myometrium is due to hypertrophy of the myocytes with a limited hyperplasia as well. You can see the fibrous tissue is also getting increased, which will add the strength to the uterus to accommodate the growing fetus. So why all these changes are happening during pregnancy is because of estrogen and progesterone, which are continuously secreted during the pregnant state. You can see, and the stimulus is hormonal stimulus like estrogen, progesterone, and after 12 weeks of gestation, due to increased expanding products of conception, also add to the stimuli and increase the uterine volume as well. And in pregnant state, you can see this myocytes arrangement in uterine wall, that is the myometrium. The myocytes are arranged in 3 layers: outer longitudinal, inner circular, and in between they are arranged in a figure of 8 or crisscross pattern. So this arrangement is usually differentiated in a pregnant gravid uterus. So the middle layer, which is also called as living ligatures. You can see in this picture the outer longitudinal, which acts as in a hood-like manner, and the inner circular layers which have a sphincteric action, and the middle interlacing or figure of 8 pattern acts as a living ligature, because between this figure of 8 pattern arrangement of myocytes, the blood vessels actually cross, and during contraction the blood vessels automatically gets compressed, and it will act as a compressive or tamponade mechanism, and so we will call it as living ligature. So you can see here maximum hypertrophy of the myocyte happens in the pregnancy. This is the normal non-pregnant myocyte. This is the pregnant myocyte. And the middle layer, which is arranged in a pattern of figure of 8 with intervening blood vessels. If during contraction, these muscle fibers come closer and they will constrict the blood vessels and reduce the blood loss. So it is a mechanism which is actually prevents the postpartum hemorrhage or increased blood loss during in a postpartum period or after delivery. So if you can see within the uterus itself, the major enlargement takes place in the fundus region and also the placental site. So this is the uterine changes which is seen in the pregnancy. This is before conception. This is at 16 weeks or 4 months of gestation, 7 months and 9 months. Usually at 4 months of gestation, it changes into it's a pear-shaped organ pre-pregnant state. Changes into a globular and ovoid and finally a spherical shape. Now non-pregnant, it's a pear-shaped, 12 weeks by globular, 7 months ovoid and more than 36 weeks, it goes as a spherical organ. So coming to the position of the uterus, up to 12 weeks, it's a pelvic organ. After 12 weeks, it becomes an abdominal organ because it enlarges in size. After 12 weeks, it comes in contact with anterior abdominal wall and it displaces the abdominal organs laterally. So finally, with the growing gestation, it reaches up to the liver as well, because up to epigastrium, by 36 weeks of gestation, it goes up to epigastrium and it reaches almost to the liver. So during this ascent, usually the uterus rotates towards the right side because of the rectosigmoid, which is present in the left side of the pelvis. So there is a slight dextro-rotation of the uterus. So what is going to happen to this isthmus? So we've talked about uterus. Uterus is having a part called as isthmus, which actually lies between anatomical and histological internal os. This is the part of isthmus. Usually in a non-pregnant state, isthmus is a connecting link between the cervix and the uterus. But in pregnant state, in the later stages of the gestation, usually this isthmus converts into the lower uterine segment. This is the lower uterine segment. So this is the segment which has a clinical significance, like during cesarean section will give a lower segment incision on this area. So the lower segment of the uterus, usually here it is having a circular muscles. As I've already said, the innermost layer of the uterus wall is a circular muscle layer which acts as a sphincteric action. So due to this sphincteric action, the gravid uterus have a competence to carry the fetus. So if the sphincteric action is at loss, usually patient will end up in incompetence with a mid-trimester miscarriages. So usually this uterus, with the gestation itself, the uterus has, the pregnant woman usually perceive irregular, infrequent, spasmodic contractions of the uterus, which are usually sustained or which usually stays for less than 30 seconds. The low pressure, they will come, they will go. They are infrequent and irregular. When the gestation is going to the term, these contractions become more frequent and regularized, and they will usually merge with the true labor pains. So when these Braxton Hicks contractions, usually in the earlier gestations, they are irregular and infrequent without any cervical changes. But as the pregnancy goes on, when the pregnancy is coming to the term, these contractions become more regularized, more frequent with cervical changes as well, and merge into true labor pains. So coming to the functional changes which happen in uterus, starts with uterine placental blood flow. In a non-pregnant uterus, if you can see, the majority of the uterus is supplied by uterine artery followed by ovarian artery. But in a pregnant state, the ovarian artery supplies the blood supply as equal as the uterine artery. So in non-pregnant state, majority of the blood flow is from uterine, and in pregnant, both uterine and ovarian artery gives the blood supply to the uterus in equal proportions. And this blood supply is for exchange of essential substances between the fetus and the mother. And the adequate perfusion is actually maintained in the placental intervillous space. To maintain this adequate perfusion, the average intervillous place perfusion is 500 to 750 ml per minute at term. And the uterine artery, if you can see, its diameter gets doubled by 5 months of gestation. Thereby, it increases the flow in the uterine artery. And these changes are mediated by estrogen due to vasodilatation, and it reduces the vascular resistance by progesterones. And PIGF and VEGF, in placenta inhibiting growth factor and vascular endothelial growth factor, actually they stimulate or they promote angiogenesis. Angiogenesis is formation of new blood vessels, and NO synthase. NO synthase forms nitric oxide, which actually helps in vasodilation. So all these estrogen, progesterone, PIGF, VEGF, and NO, usually they will help in increasing the uteroplacental blood flow by vasodilatation and vasodilatation and decreasing the vascular resistance. So what is the clinical significance of VEGF and PIGF? You can see in a preeclamptic patient, preeclampsia is hypertensive disorder in a pregnancy. If you see in a preeclampsia patient, this VEGF and PIGF levels are low. Why? Because this signaling is actually maintained by this SFLT1 like receptor, soluble FMS like tyrosine kinase 1 receptor. So when this receptor is present, it actually inactivates this VEGF and PIGF. When it inactivates this VEGF and PIGF, there is no or there is decreased angiogenesis, there is decreased vasodilation, which actually leads to preeclampsia. So this is the clinical significance of VEGF, PIGF and soluble FMS like tyrosine kinase 1. Usually in a pregnant uterus, there is a vascular insensitivity to vasopressor effects. Vasopressor effects are like if epinephrine and norepinephrine is acted on normal blood vessels, usually their action is a vasocompression. So in a pregnant uterus, if you give a norepinephrine, usually these uterine vessels are insensitive to this vascular compressive effects of norepinephrine. So this insensitivity also increases uteroplacental blood flow. So coming to the changes that happens in the cervix. The cervical changes start as early as 4 weeks of gestation by Goodell sign, which is softening of the pregnant cervix. This is due to increased vascularity and edema of the entire cervix. If you see the connective tissue of the cervix in a pregnant woman, usually the connective tissue remodeling happens. That is the connective tissue which is formed by collagen, proteoglycans. The proportions or the fractions of these collagen and proteoglycans change during pregnant state and the cervix become soft. This connective tissue remodeling decreases the collagen and proteoglycan concentration and increases the water content. So when it increases the water content and decreases the collagen content, usually the cervix becomes so soft and edematous. And this is regulated by again estrogen and progesterone metabolism. So this is the cervical cervix, where if you can see here, this is highly vascular. Therefore, if, on examination, there will be a bluish hue of the cervix, which we call it as Chadwick sign. So this is the glandular the glands in the cervix usually get hypertrophied. So the glands in the cervix usually get hypertrophied and they will secrete more amount of mucus, which is getting accumulated here as a mucus plug. So this mucus plug along with the immunoglobulins and cytokines, which will help to prevent the ascending infections. So at the time of labor, usually the mucus plug is getting expelled and it is shown as a bloody show. So usually at the onset of labor, the pregnant woman usually gives a complaint like mucoid plug or a bloody mixed mucoid discharge per vagina. If you see under microscopy, there is beading of the cervical. If you see a microscopy examination of the cervical smear, you will see a beading because of more amount of progesterone. And if there is a ferning pattern, you should suspect amniotic fluid leakage. And on pap smear, usually you will see atypical glandular cells which are normal in pregnancy. In a non-pregnant state, if you see an atypical glandular cells, you will grade it as AGC. But in a pregnant state, you have to take it as normal, this we call it as Aristella reaction. That is due to increased estrogen in pregnant women. So coming to vagina and vulva, more amount of vascularity is seen in pregnant vagina and vulva. Thereby, congestion or bluish discoloration of vagina is seen, which we call it as Chadwick sign. So pregnancy is usually associated with an elevated or increased risk of vaginal infection due to the immunocompromised state and increased glycogen stores in the vagina. So there is high chance of infections. And even the vaginal walls undergo changes like epithelial thickening, connective tissue loosening, and smooth muscle cell hypertrophy. So pregnant women usually have a physiological increase in vaginal discharge, which we call it as leukorrhea. The vaginal discharge is increased, which is rich in glucose, lactic acid, and low vaginal pH, which will actually attract more amount of infections. If you see ovaries, they are slightly enlarged. In some women, usually the corpus luteum. Corpus luteum is the luteinized thecal lutein cells after ovulation, which will actually secrete HCG up to 10 weeks of gestation, and after that there will be a transplacental shift. This HCG is actually secreted by placenta, but up to 10 weeks, this corpus luteum will secrete HCG to actually support the pregnancy. So when this corpus luteum function is increased, then we will call it as this hyperreactio luteolanis. So the ovary becomes more enlarged with multiple cysts. And fallopian tubes, there is little muscular hypertrophy with flattening of endothelium. And relaxin is a hormone which is secreted by corpus luteum, decidua, and placenta with functions like increased renal hemodynamics, increased serum osmolality, and increased uterine artery compliance as well. So what are the structural changes that happen in breast? Usually in a pregnant woman, there is a little bit of engorgement with a venous prominence. Some people usually complain of mastodynia. Mastodynia means breast tenderness, which will actually have a spectrum of symptoms like mild tingling to a frank pain. This is due to hormonal responses, and the sebaceous glands which are actually surrounding the areola, usually they get enlarged. When this enlarged sebaceous glands are seen around the areola, we'll call it as Montgomery tubercles, which are actually seen in pregnant. And colostrum is the first milk which is usually seen after first few months of gestation. And some people usually have a complaint like gigantomastia, usually during postpartum, and need surgical intervention. This is gigantomastia. The breast milk gets accumulated, and if there is any infection, they'll get tenderness and mastitis and gigantomastia. Some people usually require a surgical intervention. Coming to the skin changes, usually skin changes, we can see a vascular dilatation of small capillaries, which is seen as vascular spiders, and stria gravidarum are seen on abdomen, thighs, and breasts. And hyperpigmentation in the midline, which we call it as linea, which is due to estrogen and melanocyte stimulating hormone. And chloasma and melasma are usually seen on the face. The hyperpigmentation patches on cheeks and nose, and skin navy and palmar erythema are also common. So this is melasma and chloasma, the hyperpigmented patches on cheeks and the nose. On abdominal wall, these are stria gravidarum laterally, and this is the midline hyperpigmented linea nigra. So this pigmented skin line in the midline of the anterior abdominal linea nigra. And after delivery, if you see these pigmentary changes, usually they will disappear, but sometimes they will be left as a linea albicans and linea alba, stria albicans. So coming to the weight gain, the normal weight gain according to BMI in pregnant state is, if the woman is underweight, according to BMI, if the woman is underweight, that is less than 18 kg per meter square, the weight gain is 12 to 18 kg. 18 kg. For a normal BMI women, adequate weight gain is 11.5 to 16 kg. In an obese woman, it should be 7 to 11.5 kg. and in an overweight woman it should be 5 to 9 kg. This is the appropriate weight gain according to the BMI of the women. This BMI is usually will calculate in the early pregnancy or in a pre-pregnant state. So this weight gain usually is again because of due to increased maternal tissue and growing fetus. So the fetus actually occupies 3.3 kgs with a placenta of 0.6 kgs and liquor 0.8 kgs. Uterus gives 0.9 kgs, breast 0.4 kgs, fat and protein 3.5 kg, and blood volume, increase in blood volume in the mother goes up to 1.3 kg and extracellular fluid 1.2 kgs. So if you add all these, the appropriate weight gain should be 11.5 to 16 kg in a normal BMI women. So in a pregnant woman, usually there will be retention of sodium and water due to estrogen and progesterone, and activation of renin-angiotensin system will increase aldosterone. In turn, actually it will cause retention of sodium and water and antidiuretic hormone. So all these factors cause retention of electrolytes. And accumulation of tissue fluid, if you see, usually they will be accumulated in the lower extremities due to decreased colloidal osmotic pressure and increased venous pressure by the growing gravid uterus on the iliac veins. The gravid uterus usually compresses on the iliac veins and it increases the venous pressure, which will increase the physiological edema in pregnancy. So what is the significance of weight gain? So if you see a pregnant woman with a rapid like 0.5 kg, more than 0.5 kg in a week or more than 2 kg per month, you should suspect a preeclampsia. If the woman has a falling weight gain, then you have to suspect a growth restriction or an intrauterine death. So coming to the blood changes or the hematological changes that happens in pregnancy. So if you see the blood volume, usually it increases by 40%, plasma volume by 50%, and red cell mass means red blood cells, increase by 20 to 30%. So there is a disparity of increase in plasma volume with the red blood cell volume. Therefore, there is a physiological anemia in pregnancy. So there is increase in total hemoglobin by 20%. So what is, I said this the physiological hemodilation or physiological anemia or relative hemodilation. There are some advantages due to this relative hemodilation. Because the plasma volume is increased and blood cell volume is not increased to up to mark, there will be a relative low viscosity in the blood. So there is decreased blood viscosity, thereby the perfusion gets better and the perfusion to the fetus is increased, and it protects from the adverse effects of supine hypotension and protects against adverse effects of blood loss in the postpartum period. So the blood volume, this is a summarization, the blood volume increases by 40 to 45%, dilutional anemia with hemoglobin 11 grams, leukocytosis, white blood cells increases by 15,000 per microliter, platelets usually there will be a thrombocytopenia because of this dilution thing slightly reduced. If you want to define a thrombocytopenia, it should be less than 2.5 percentile or less than 1 lakh, and erythrocyte sedimentation rate increases to 40 mm per hour. And pregnant state is a hypercoagulable state, and there is increased risk of thromboembolism. So because it's a hypercoagulable state, there is increased in clotting factors like fibrinogen, factor 8, factor 7, 9, 10 and 12. And factor 11 and 12 usually they will get decreased. So prothrombin time and activated plasma partial thromboplastin time is shortened and fibrinolytic activity is reduced. When the fibrinolytic activity is reduced, there is more amount of clotting or hypercoagulable state. So coming to the cardiovascular changes, the structural changes that happen in the CVS are heart is pushed upward, outward and upward and outward. Thereby the apex shifts to fourth intercostal space 2.5 centimeter lateral to midclavicular line. You can see here heart is shifted upward and lateral and the apex is shifted to fourth ICS. And there is a physiological systolic murmur due to hyperdynamic circulation in the pregnant woman. So you can see a continuous murmur in second and third intercostal space due to increased mammary circulation, which we call it as mammary murmur, and increased in left ventricular end diastolic diameter and even atrial diameters. And S3 can be auscultated. If you see on ECG, there is left axis deviation. So all these changes you have to be knowing, because these are physiological changes and you have to differentiate it from a pathological cardiovascular disease in a pregnancy. So stroke volume increased by 30%, heart rate by 15%, cardiac output increases by 40%, and oxygen consumption is increased by 20%. And the systemic vascular resistance is decreased by 20%. You see a systolic BP is reduced by 10 and diastolic BP by 15 mmHg. So stroke volume is the amount of volume which is being pumped with a single in a single pumping of the ventricular action, which is more than 30%, and heart rate is 15%. Cardiac output for a 1 minute, so stroke volume into heart rate is a cardiac output. And if you see throughout the pregnancy, the cardiac output increases during 32 weeks of gestation and second stage of labor and immediate postpartum period. So these periods are actually, the pregnant woman is more vulnerable for cardiac failure in these periods. In a pregnant woman with cardiac disease complicating pregnancy, usually the compensatory changes, or she is at risk during this period, 32 weeks during labor, that too in second stage of labor, and in immediate postpartum period, because there is increased cardiac output during these periods. So inferior vena cava syndrome or the supine hypertension syndrome. In the supine hypertension syndrome, if the pregnant woman is lying in a supine position, usually the inferior vena cava is getting compressed due to gravid uterus. So this results in decreased cardiac output, decreased output or decreased venous return to the heart. Thereby, women feels dizziness and lightheadedness, syncope, or she will faint. So at that time, usually you have to change the position of the pregnant woman from supine to left lateral position, which increases the cardiac output by 20%. So this will happen. If she is lying in a supine position, there is compression of this inferior vena cava and it will decrease the cardiac output or venous return to the heart. Thereby she will feel dizziness or she will get fainted. So you have to tilt the patient to the left lateral, which will reduce this compression on the inferior vena cava. Why this happens in only some women? Because usually in a pregnant woman, there are collateral circulation that happens in the vertebral circulation as well. In some women, usually it doesn't get established. Therefore, they will usually complain of this supine hypotension syndrome. So coming to the cardiovascular changes, venous changes. Venous pressures are usually unchanged in the upper body, as we have already read. The lower limbs venous pressure is increased due to compression of growing gravid uterus on the low iliac veins. So major pressure changes are seen during sitting and standing positions. This is the metabolic changes. The basal metabolic rate increases and weight we have already talked about in the previous slides. And water retention, pregnant state, in a pregnancy, it is a state of retention of water and electrolytes, as we have already mentioned, due to estrogen, ADH, and angiotensin, RAS, aldosterone. So in a pregnant woman, usually you can see a physiological edema, which is pitting type, and it will reach up to ankles. This is due to decreased colloidal pressure and increased pressure on the iliac veins. So protein metabolism, usually at term by 4 kg, placenta and uterus requires 500 grams of protein, and this is the various organs which require proteins. And carbohydrate metabolism, pregnancy is a diabetogenic state. In a normal pregnancy, if you can see, we'll see a mild fasting hypoglycemia with a postprandial hyperglycemia and insulin resistance. This is the physiological changes that happen in a pregnancy. Fasting hypoglycemia, postprandial hyperglycemia with insulin resistance and hyperinsulinemia. Why this insulin resistance happens? This is due to this human placental lactogen and which actually, and estrogen progesterones, which actually leads to higher lipolysis and increased free fatty acids. which will increase the resistance to insulin. Coming to fat metabolism, usually in the first 2 trimesters there is lipid synthesis, and third trimester lipolysis is seen. Lipolysis increases or it will gives lipid as energy source for the mother, and which will spare glucose and amino acids for the fetus. So leptin is in a non-pregnant state usually seen in adipose tissue, but in a pregnant woman usually placenta secretes leptin hormone at a rate of 2 to 4 times, and its levels are usually elevated in preeclampsia and GDM. Ghrelin is also a peptide hormone which is responsible for hunger. And coming to iron metabolism, the requirement of iron increases from 2 to 3 milligrams to 6 to 7 milligrams in the later trimesters. In the earlier trimester, iron requirement is only 2 to 3 milligrams, and in later trimester, it goes up to 6 to 7 milligrams. And during lactation, it is 1 milligram. So what all iron you are taking, only 10% is getting absorbed. And out of which 75% of the absorbed iron is usually meant for hemoglobin. So iron is actively transferred through the placenta, and requirement is 1000, which is required, 500 is required for maternal red blood cell, increase in maternal red blood cell, and for fetal development 300, and 200 compensates the normal iron losses. Coming to the calcium requirement, required daily allowance is 1 to 1.5 grams. So we usually supplement with 1 gram of calcium for a pregnant woman. Usually the ionized calcium has a physiological function, and the calcium absorption increases. Calcium absorption is increased during pregnancy, but phosphates in mother remains unchanged. The renal changes, coming to renal changes, the kidneys are usually, there is mild enlargement of kidney. The renal plasma flow is increased due to increased renal vasodilatation, thereby increases the glomerular filtration rate, and it decreases the serum creatinine and uric acid. In pregnant state, there is a glucosuria because the threshold for a glucose is reduced, and there is less tubular absorption of the glucose. These are the structural changes that happens in kidneys. The renal pelvis gets dilated, ureter is dilated, bladder tone is reduced, capacity is reduced, residual volume is increased, and there is high chance of pyelonephritis. All these changes are mediated by progesterone. Progesterone is having a muscular relaxation activity, which will relax the renal pelvis, ureters, and bladder as well. Thereby there is high chances of stasis of the urine, and there is high risk of infections, and there is high chance of pyelonephritis. Coming to the lung changes, the structural changes are, there is mild mucosal hyperemia. If you see a nasal congestion and a nasal mucosal hyperemia, and the subcostal chest circumference diameter and chest circumference diameter increases, and the subcostal angle increases from 68 to 103 degrees, and functional residual capacity increases by 20 to 30%. See, the subcostal angle increases from 68 to 103 degrees centigrade, and the chest circumference increases by 5 to 7 centimeters, and the diameter increases by 2 centimeters. So the respiratory rate is unaffected, the vital capacity is unaltered, the tidal volume is increased by 30 to 40%, residual volume is reduced by 20%, the inspiratory capacity is increased by 10%, and the minute ventilation increased by 30 to 40%. These changes are stimulated by progesterone. So pregnant state is a mild respiratory alkalosis. That is, respiratory alkalosis means more amount of PaO2 and less PaCO2. The residual volume is actually reduced in a woman. The pregnant woman residual volume is reduced when compared to a non-pregnant woman. This is again a pictorial representation. Coming to the GI changes, usually pregnant women will complain of morning sickness, which is normal in a pregnant woman. This is actually having many hypotheses like increased estrogen, HCG, progesterones. Progesterones usually they will cause so relaxation of the sphincters. And if this morning sickness is aggravated, or it is having a the severity is increased with features like weight loss, ketonemia, and electrolyte imbalance, we'll call it as hyperemesis, where the women needs hospital admission and treatment. Usually, some women will have a dietary craving for a non-nutritional substances like slate pencils or sand, which we call it as pica. And the gastric motility is decreased due to progesterone activity, and the sphincteric action is also relaxed, which will cause reflux and heartburn. And there is atonicity of gallbladder, and there is high chances of cholestasis and gallstones formation. This hyperemia and softening of the gums, increased chances of hemorrhoids, and appendix is displayed laterally, and liver enzymes are lowered. So the nervous systems are temperamental changes are not infrequent in women, but they are rarely seen. And nausea, vomiting in pregnancy, irritability, sleep disorders are usually have a nervous system role as well, and a psychological role as well. The compression of median nerve and lateral cutaneous nerve of thigh causes paresthesia, because pregnant state is a state which we have already seen that a lot of accumulation of water happens, and thereby it will compress the median nerve and lateral cutaneous nerve of thigh, causing paresthesia. Postpartum blues, depression, and psychosis is usually seen in a susceptible women. Coming to the endocrine changes, if you see thyroid gland, the thyroid gland is slightly enlarged with hyperplasia, but usually the women remains euthyroid. That is, the thyroid gland is enlarged, but still thyroid hormone levels, if you check on a blood investigations, usually she will be euthyroid. This is due to increase in thyroid binding globulin due to estrogen. There is a transient fall in free T3 and T4. Therefore, it increases the production of TSH and thereby thyroid hyperplasia. This is because of thyroid stimulating action of HCG. In a pregnant state, there is increased HCG, which also acts as thyroid stimulator and activates the thyroid gland. Thereby, it increases the TSH and T3, T4 as well. So it increases the total T3 and T4. Therefore, in a pregnant woman, usually we will check TSH, free T3 and free T4 levels. So fetal thyroid function usually starts by 12 weeks of gestation. So adrenaline glands, you see there is an expansion of zona fasciculata, which is the site of glucocorticoid production. And plasma corticosteroid binding globulin increases. This is due to increased liver synthesis. And free plasma cortisol level increases due to delayed clearance, and plasma deoxycorticosterone also increases due to fetal-placental unit stimulation. Coming to pancreas, there is hypertrophy and hyperplasia of the beta cells of pancreas, because pregnancy is a insulin resistant state. So if the woman is in fasting, usually it is associated with accelerated starvation. There will be maternal hypoglycemia and reduced insulin levels and hyperketonemia. And due to diffusion of glucose by the fetoplacental unit, if the mother is on fasting, there is diffusion of glucose, remaining glucose to the fetoplacental unit, which will actually end up in maternal hypoglycemia and hypoinsulinemia with increased ketone body formation, because the fatty acids are converted into ketone bodies. In the feeding state, usually they will have mother will have a hyperglycemia with increased insulin, increased triglycerides, and reduced tissue sensitivity to insulin. So the peripheral resistance to insulin is a diabetogenic, as we have already seen, due to human placental lactogen and cortisol mediated. The pituitary changes which happen in pregnancy are enlargement of pituitary gland with anterior pituitary hormones like prolactin. Usually it is increased during gestation, and mostly postpartum it is we'll see a marked increased even prior to labor and after labor, because it prepares the breast for lactation. And FSH and LH usually they are reduced, because increased levels of estrogen and progesterone, they will have a negative feedback on FSH and LH, and growth hormone is decreased. Posterior pituitary hormones like oxytocin, if you see the levels of oxytocin, usually they will get increased. Even receptors and the levels increase by third trimester, and whose level peaks in labor because they will mediate uterine contraction. The musculoskeletal changes in a pregnant woman, a lordosis is seen to keep the center of gravity over the legs, and due to this lordosis, usually patients will complain back pain. The relaxin hormone causes relaxation of pubic symphysis and sacroiliac joints, which will facilitate vaginal delivery, but may also lead to discomfort due to this relaxation. Any doubts?